Welcome to This Week in Emergency Medicine. This week we are covering 10 notable papers spanning advanced airway and ventilation management, post-arrest and pediatric sedation strategies, and diagnostic challenges in cardiovascular and reproductive emergencies. Let's dive in. We begin with critical airway management in the emergency department, where a prospective registry study, practice patterns, and outcomes of emergency physician-performed awake tracheal intubations. Over a 10-year study period at an academic tertiary care emergency department, researchers screened over 1,200 intubations and identified 87 cases of awake tracheal intubations performed by emergency physicians, representing about 7% of all intubations. The vast majority of these patients had documented predictors of difficult intubation, with 80% presenting with anatomic difficulty, 87% with physiologic difficulty, and over two-thirds having both. Remarkably, overall success without any major adverse events, defined as critical hypoxemia with oxygen saturation below 80%, critical hypotension with systolic blood pressure below 65 millimeters of mercury, or cardiac arrest, occurred in 92% of patients. First-pass success was achieved in 71% of cases, and only about 7% of patients required conversion to rapid sequence intubation. The rates of critical hypoxemia, critical hypotension, and cardiac arrest were low, occurring in 3%, 2%, and 2% of patients, respectively. These findings suggest that when emergency physicians are properly trained, awake intubation is a highly successful airway management strategy with a favorable safety profile for patients with complex anatomy or physiology. Moving from airway establishment to ongoing respiratory support, a publication in the Annals of Internal Medicine addresses the utility of high-flow nasal oxygen therapy compared to standard oxygen therapy in patients presenting with acute hypoxemic respiratory failure. This review concluded that high-flow oxygen therapy did not reduce mortality at 28 days compared to standard oxygen therapy. This suggests that while high-flow nasal oxygen remains a valuable tool for patient comfort and reducing the work of breathing, clinicians should not expect a primary survival benefit from its routine selection over standard oxygen delivery systems. Meanwhile, for patients in active cardiac arrest who have an advanced airway in place, the choice of ventilation mode remains highly debated. A systematic review and meta-analysis published in the journal Resuscitation evaluated volume-controlled mechanical ventilation against manual ventilation or other ventilation modes during cardiopulmonary resuscitation. Screening over 12,000 abstracts, the investigators analyzed 13 articles consisting of 6 trials with over 400 patients and 7 non-randomized studies with over 4,600 patients. The meta-analysis revealed no significant difference in the rates of return of spontaneous circulation between volume-controlled mechanical ventilation and manual ventilation. Furthermore, comparisons to pressure-controlled or cardiopulmonary resuscitation-specific modes were highly limited, and the overall certainty of evidence was graded as very low to low. For practicing clinicians, this means there is currently no high-quality evidence suggesting that mechanical volume-controlled ventilation is superior to traditional manual bagging during active resuscitation, though mechanical ventilation may still offer operational advantages in resource-constrained environments. Next, we turn to the critical management of sedation, both in the immediate post-arrest phase and during pediatric procedures. In the journal Resuscitation, researchers analyzed data from the prospective AFTER-ROSC-1 and AFTER-ROSC-2 cohort studies to evaluate the impact of early sedation started during pre-hospital care after out-of-hospital cardiac arrest. Among nearly 1,600 patients analyzed, 83% received sedation before intensive care unit admission, while 17% did not. Interestingly, the patients who did not receive early sedation had lower disease severity scores, suggesting that clinicians may intentionally withhold sedation from less ill patients to facilitate early neurological assessment. While the sedated group initially appeared to have a significantly higher proportion of patients with favorable neurological outcomes at 90 days, representing more than double the adjusted odds of a good recovery, this association lost statistical significance after applying propensity score adjustment. This highlights a classic indication bias, indicating that the decision to sedate is heavily influenced by the patient's baseline severity, and underscores the critical need for randomized controlled trials to determine whether early post-arrest sedation truly improves functional recovery. In the pediatric emergency setting, procedural sedation often presents a challenge, particularly in children with severe needle phobias. A clinical review. After reviewing 8 relevant clinical studies, the authors concluded that while intranasal ketamine carries a slightly lower likelihood of overall procedural success compared to intravenous ketamine, it represents a highly valuable, needle-free alternative. For clinicians, this highlights the importance of shared decision-making with parents. Explaining the trade-off of a slightly lower success rate in exchange for avoiding an intravenous line is an excellent strategy for highly anxious or needle-phobic children. We now focus on cardiovascular and pulmonary vascular emergencies, beginning with a major therapeutic update for intermediate-risk pulmonary embolism. This study demonstrated that adding ultrasound-facilitated catheter-directed thrombolysis to standard anticoagulation therapy significantly reduced a composite adverse clinical outcome within 7 days compared to anticoagulation alone. This finding supports a more aggressive, catheter-directed intervention strategy in select patients with intermediate-risk pulmonary embolism who show signs of right ventricular strain but are not yet in overt obstructive shock. Meanwhile, clinicians frequently encounter the diagnostic challenge of elevated cardiac biomarkers in patients with underlying kidney disease. A clinical review in the Canadian Journal of Emergency Medicine explored the complex puzzle of interpreting positive troponin results in patients with renal disease. Patients with chronic kidney disease often have chronically elevated baseline troponin levels due to decreased clearance and ongoing subclinical myocardial injury, which can easily be mistaken for an acute coronary syndrome. The authors emphasize that clinicians must rely heavily on serial troponin testing to identify a significant rise and fall, alongside electrocardiogram findings and the patient's clinical presentation, to avoid inappropriate diagnoses and unnecessary invasive investigations. Turning to obstetric emergencies, point-of-care ultrasound has revolutionized the emergency department evaluation of early pregnancy, but choosing the right tool is essential. A paper in the Canadian Journal of Emergency Medicine discusses the diagnostic accuracy and utility of utilizing high-frequency linear transducers as an adjunctive tool in first-trimester pregnancy point-of-care ultrasound. While low-frequency curvilinear probes are standard for transabdominal pelvic imaging, high-frequency linear transducers offer superior spatial resolution close to the abdominal wall, which can help clinicians identify very early intrauterine pregnancies or subtle adnexal masses in thin patients. However, obtaining formal diagnostic imaging can often lead to dangerous delays. Another study in the Canadian Journal of Emergency Medicine investigated the clinical and operational costs of waiting for formal radiology-performed diagnostic ultrasounds in cases of suspected ectopic pregnancy. Delays in obtaining these diagnostic scans not only prolong emergency department length of stay and consume valuable resources, but also potentially delay life-saving surgical or medical interventions for patients with ruptured ectopic pregnancies, highlighting the critical role of timely emergency department point-of-care ultrasound in mitigating these risks. Finally, in the realm of clinical toxicology, the Canadian Journal of Emergency Medicine published a practical review on the use of fomepizole as an adjunctive therapy for massive acetaminophen overdoses. While acetylcysteine remains the cornerstone of acetaminophen toxicity management, massive ingestions can saturate the standard treatment pathways, leading to ongoing liver injury. Fomepizole acts as a potent inhibitor of the cytochrome P452E1 enzyme, which is responsible for metabolizing acetaminophen into its highly toxic metabolite, NAPUI. By halting this metabolic pathway, fomepizole serves as a powerful adjunct to acetylcysteine in severe overdoses, potentially preventing fulminant hepatic failure and the need for liver transplantation. If you only have time for one paper this week, make it the prospective Registry study on emergency physician-performed awake intubations. This paper provides robust, real-world evidence that awake intubation is not just an anesthesia suite luxury, but a highly successful, safe, and viable airway management strategy that emergency physicians can and should utilize for their most challenging patients. Here are the key takeaways from this week in emergency medicine. First, emergency physician-performed awake intubation is highly successful and safe, achieving a 92% success rate without major complications in patients with difficult airway predictors. Second, in patients with intermediate-risk pulmonary embolism, consider the addition of ultrasound-facilitated catheter-directed thrombolysis to standard anticoagulation, as it significantly reduces adverse clinical outcomes within 7 days. Third, high-flow nasal oxygen does not reduce 28-day mortality compared to standard oxygen therapy in acute hypoxemic respiratory failure, so its use should be guided by patient comfort and work of breathing rather than survival expectations. Fourth, volume-controlled mechanical ventilation during active cardiopulmonary resuscitation does not improve the rates of return of spontaneous circulation compared to manual ventilation, meaning manual bagging remains an acceptable and effective standard. Finally, for pediatric procedural sedation, intranasal ketamine is a valuable needle-free alternative to intravenous sedation, though clinicians should counsel parents that it carries a slightly lower overall likelihood of success. That's your roundup for this week in emergency medicine. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary for clinical decisions. Always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.